سيدنا محمد عليه أفضل الصلاة وأتم التسليم. Good morning. It's my pleasure to be here with you and attend this interesting topic, the intraoperative blood salvage, which is the first in its kind. And also I would like to thank our staff in blood bank team led by Mr. Abdullah Al-Harbi, blood bank supervisor who succeeded arrange this topic with Dr. Omar and Livanova company, Arabian Trade House, which I hope can help you in transfusion issues. I don't want to take a long time. It's my pleasure to welcome Dr. Omar الرضوان. He's a consultant cardiac anesthesiologist, King Faisal Specialist Hospital. Welcome, Dr. Omar.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, ladies and gentlemen. So I'll speak in English, if you don't mind. So first of all, I would like just to thank Mr. Abdullah Harbi for the kind invitation and the blood bank service and King Fahd Hospital here in Qasim. It's like my second time to present, which is like I'm always honored to come here and to share with you some experiences, sharing our own experience. I think you know all this information, but the discussion, this is what we want to achieve. The discussion, I would say, communication, passing the experience from one hospital to other. I work in this beautiful hospital, Riyadh, over 1,000 bed hospital, 1,000 bed. We're gonna have like soon open in the King Abdullah Center, which will add another 400 bed. It will be like a huge hospital in Riyadh, serving the whole country. I'm proud to be a member of this prestigious institution. In this hospital, we do all kind of complex procedure, high-risk procedure. We are the liver transplant center, probably one of the liver transplant center, the biggest in the region. Over 150 liver transplant per year. We are the only lung transplant center in the region, oncology center, and of course the complex cardiac procedures. So all these procedures need a support from the blood bank because those procedures are associated with, high risk of bleeding. What we know, of course, blood and blood products, expensive, okay, and not always available even if you have money. Associated with complications. And what we want to explore in this lecture is alternatives. Is there any alternatives to reduce the demand on the blood and blood products? Our blood bank, they're under the leadership of Dr. Hind Al-Ahmedan, doing a great job to meet the increase in demand of blood products in our hospital. Every year they add extensive and expensive testing. This will add, of course, to the cost of the blood. We are planning to do liquid reduction universal, so we do have every unit will be liquid reduced. Viral inactivation, another plan, also will add to the cost. And even we have like this one, the octoplasm, this one that alternative to the current FFP. So the unit of blood in our hospital every year increases in the price, So now it's hitting about 1,400 riyal. And I don't know how with Zika virus, with all this virus every year emerging, what we have to do, the NAT technology, okay, and whether we'll continue NAT technology in Ministry of Health in the whole country, we'll see how it goes. So why we need the blood? We need the blood, of course, for simple reason that we have to improve the oxygen carrying capacity. And we assume that increased hemoglobin level will increase oxygen delivery and consumption and decrease morbidity and mortality. This is the assumption, and that's why we need the blood. That's why the surgeons will need the blood, and anesthesiologists will ask for blood before we go ahead with surgery, because the blood is essential for oxygen carrying capacity. And we know that this will, anemia and post-operative anemia and the bleeding associated with complications, morbidity, and mortality. Let's have a flavor of the Saudi Arabia. Blood bank in Saudi Arabia, over 200 blood bank now, and most of the source of blood in our country, they come either from voluntary donor, family replacement donor, paid donors, not like allowed in this country. So voluntary donor, when you go to hospital, it varies. In my hospital, we claim about 40-50%. voluntary donor, الطوعي. بينما family replacement donor about 50-60%. You go some hospital in Saudi Arabia to reach 80%. I don't know about here in Qasim, but you see, it's still, even in King Faisal, we ask patients to bring donors from their own family, okay? It's a fact. And some blood bank even depend on the driver license, and they depend on certain, source of blood. So, is there any problem with family replacement donor? This is a study from Egypt, and in Egypt, the family replacement donor probably 95%. And what they found compared family replacement donor to a donor طوعي, or voluntary donor. And what they found in family replacement donor, full of infection, syphilis, HIV, hepatitis, all kind of these one. And the question here is this something like it's also applicable in Saudi Arabia, the family replacement, of course, family replacement donor. We have like a few months ago, a patient from Hafr al-Batin, and we asked him to bring his family to donate. Like the whole tribe came, and one of his relative came and he said, listen, my blood is not good. I'm telling you from now, my blood is not good. But please just put a needle, just as if I donated blood, okay, for my cousin. But I know I travel a lot, and this one, my blood is not good for my cousin or for any other. So this is like a problem, Well, they will tell the good history or this one, this is a problem. That's why we see this one in Egypt. نقطة الدم تساوي وفاة. One drop of blood called heat. In Saudi Arabia, this guy from High, close to you, he get like here. We don't know whether he get it from King Fahd Medical City or he get it from High. We don't know. This lady, we know her, Riham, okay? And she came to us in King Faisal. She could try to King the HIV. So it is a way. It's not common, but you see, we are working hard, to recruit donors, voluntary donors. But we see the public now, they have certain awareness problem also. Some of them, they said, we don't have enough time. This is the public awareness of blood donation in central Saudi Arabia here, in this region. No enough time, unable to access blood bank. At one point, our patients or our visitors, they couldn't have a parking. They have to park far away from the hospital to get the blood bank. Why is that? Family discouragement, don't go, don't donate. Fear of anemia, probably I will have faqr dam, okay? Fear of infection, fear of needles, okay? All these concerns of the public, and even like you see, half of the population, the females in Saudi Arabia, they don't donate, okay? And they don't donate because of what? Is there any good reason for that one? We will discuss it, but you see, still there is room for improvement for female donation. Still we have female donors sometimes in King Faisal, but still the percentage is very low comparing to the West. Let's say, blood banks now in Saudi Arabia is like, we have like over 200 blood banks. We have the AABB accreditation, which is the highest accreditation in the world. Probably 10 to 12 blood bank only in Saudi Arabia, including King Faisal, is AABB accredited. What does it mean? That I'm AABB accredited King Faisal, I will not be able to take blood from non-AABB accredited center. So I cannot take blood from Shimesi, cannot take blood from military, cannot take blood from King Fahd Medical City. I cannot take blood from it, okay? This is where the AABB accreditation, I only can take blood from National Guard because they are AABB accredited centers. Of course, this AABB accreditation doesn't come without cost. Of course, all the paperwork, the setup, the investigation, the labor, the investigation, all these one cost, and this will add to the cost of the blood and blood products. Of course, the NAT technology now, and I know that the NAT technology, I think you have it here, the NAT technology, and it is actually widely used in Ministry of Health. The question now, of course, it's not technology. It means what nucleic acid test. It will test, for example, whether this patient has hepatitis B or C, and even in the incubation period, it will not depend on the antibodies. So this NAT technology also expensive. It's not cheap. And now, and I had a meeting with the center, with most of the blood bank supervisor a few months ago, and they said, well, the ministry is revising this one, whether we need this NAT technology or not. Is this cost effective or not? Should we continue? It has a cost. And what you see here, that this NAT technology, in King Saud, for example, University, King Khalid University Hospital, 2 years, they could detect probably 2 patients out of 2 years that they have like hepatitis B and C, and they found like if there is like no NAT technology, this will be missed, and probably this blood will be transfused without knowing. So that's why this is the claim that this is not technology. But we have to convince now the higher, cabinet, we have to the ministry that this is really cost effective. And I don't know about the future of NAT technology, Minister of Health, whether it will continue or not. In King Faisal, according to ABB, we have to continue this one. Like you see, because with certain countries they don't have NAT technology. Who's from Jordan here? Anybody from Jordan? So if I go to Jordan, I donate blood. You take my blood as a Saudi. By law, in Jordan, they only take blood from Jordanian, okay? And why is that? Because they don't have like NAT technology, they don't have this. They said, well, we cannot trace patients if they have infection in this one. And they have many people, foreigners from Iraq, from Syria, from Egypt, and also they have Saudis patients, they go, and they are not by law. And this is like, let's say, this Jordanian, okay, they only take blood from Jordanian. But here in Saudi Arabia, we can take blood from anybody. Like, we take blood from people who just arrived in Saudi Arabia for a driver license. We take blood from them, okay? And sometimes in certain centers, they depend on this. I went to a blood bank in Taif. They mostly depend on the driver license, blood service. The question is that we need a standard. What kind of standard that we're going to use? Is it ABB? Is it JCI? And now the old body talk about what? Sibahi. Do you have Sibahi now? We just finished the Sibahi, and I work in also Prince Mohammed bin Abdulaziz Hospital in Riyadh. We succeeded Sibahi, all happy. Okay? And this is probably the standard that will be like for all hospitals in Saudi Arabia, including King Faisal. Now we are applying also for Sibahi. Okay, so this is probably that they will have accreditation, and I don't know what kind of standard they will put for a blood bank. All what we need is the triple aim of healthcare. What we need for more healthcare? We need, of course, that the patient's experience and satisfaction. No patient wants to come and get the blood unnecessarily. No patient wants to come take a blood with infection. Okay, we need also to give the highest quality of service to our patients. If the NAT technology is essential, if the certain testing is essential, then of course, we have to give it to our patient, but, against the cost. That's the question. Now it's the cost. All my meeting now in King Faisal is about reduction of cost. And we are even getting like 1 billion extra compared to last year, but also we are, focusing on cost reduction. Okay. So what is the cost reduction? And what we are doing, we're doing some sort now more than advanced, I would say, medicine, which is protocolized medicine. So patients, when they come pre-op, there is certain protocol, intra-op, certain protocol and setup, and post-op, certain protocol and setup. It is not about now your own preference. Oh, I like blood. Oh, I don't like blood. Oh, I like to give this patient blood when he's hemoglobin of 9. I like to give blood when it's hemoglobin of 10. Oh, I don't accept, I don't. It doesn't work like right now. It works with the protocolized medicine, with something very, What is this protocolized medicine? We get something in pre-op. Before the patient comes to the OR, what can we offer to this patient to avoid the blood transfusion? Because our aim now, and they always say, can anesthesia generate money? This is what the administration asked me, say, can you generate money for the hospital? I said, yes, I can generate by reducing cost. Okay? This is what I can do. Okay? Nobody will come to me and say, oh, I would like to meet Dr. Radwan because he's a cardiac anesthesiologist and I have an appointment with him. No, I will reduce the cost, and that's why I can generate money for the hospital. So how can we do that one? Of course, before patient comes to the hospital, or before even patient goes to the OR, is he optimized? Did we treat him? Did we treat his anemia? Did we manage his medication? It's very important. So what we did, pre-op anemia, for example. It's very, very important, very common problem in the definition, WHO, males below 13, female below 12. They went to a university in Taiba, Madinah Munawwara. It's like university and girls' university. And they test those girls. And they are healthy. And they found 47% of them are anemic by definition of WHO. Okay, and that's why this is like probably it will actually prevent the Saudi female from probably donating, because most of them, they are really, by WHO, they are really, anemic. So in our hospital, and we did a study for cardiac patients, 35% of our adult patients are anemic before they come to the OR. Okay, we didn't touch them, they didn't bleed, but they are anemic. And now we are doing an audit of non-cardiac surgery, and I'm sure it's about 35-40%, because we see it a lot. If we apply this definition, some people raise this issue, is this definition below 13 for males and below 12 for females applicable on Saudi population, on our area? But this is the WHO if we want to go with this definition. As we have pre-op anemia, the outcome is worse. Those patients would then come with hemoglobin of 10 or 9, come to the OR, their outcome after surgery is worse than those patients would come with 13, because they're most likely to get a blood transfusion associated with complications. طيب, what should be the target hemoglobin pre-op? This is an important question, okay? An important question, why? Because you see, we have to see those patients in the clinic. We have to determine whether they are anemic. And if they are anemic, why they are anemic? Is it treatable cause of anemia that we can treat? This is important, okay? And based on this one, we can do the test. If they are iron deficiency anemia, we give them iron. If they're megaloblastic anemia, we give them B12. But who should do this? Is it a pre-anesthesia clinic? Should you refer them to the hematologist? Is it the family doctor? Is it the internist? The problem still, this one is lost. We don't know. Even King Faisal, I have this patient, although I prompt the people, say, please, internal medicine, see this patient, he's anemic. You have to follow him, because I cannot follow him. I will see him in the clinic, but I cannot treat him and follow all his medication in this one. The other thing is, do we have the medication? Suppose the patient comes 1 week before his surgery. Can we treat his anemia within 1 week? In UK, they have the Ferri inject. And this is like iron IV can be given to the patient. It will be enough for the 1 week, and it will quickly fix the anemia, the iron deficiency anemia. And this is what we are trying to get in King Faisal. And this one, of course, erythropoietin also has some indication, but needs some sort of hematology consultation. But this is what they do, especially if the patient comes early, like just late, and his surgery will be within 1 week. This is like a program that it's like up and running in Canada, where I did my training. This doctor is anesthesiologist. These two doctors are hematologists working together in one clinic called the Blood Conservation Program. And they see those patients, refer to them, and they do all this work. And this is likely, and by the way, their infrastructure, إمكانياتهم وكل شيء, by far lower than us. Okay? Lower, if I compare them to King Faisal, for example. Lower than us, but they are organized. Okay, this is the difference between the two. Antiplatelets is drug. Like, for example, I ask you, if the patient on aspirin, will you stop aspirin before surgery? Or will you continue aspirin? Stop or continue? Nobody will continue? Okay, so this is it. It's not about, about like our own preference. There is guideline. There is a protocol. If the patient takes aspirin because of primary or secondary prevention, suppose the patient has stent, suppose the patient has MI, suppose this patient has of course I will continue aspirin, except in one condition, if the bleeding is a problem in those patients, like closed space surgery, spine surgery, neurosurgery, ear surgery. Those surgery that's little bleeding will cause a problem. What about the Plavix? So what I want to share with you, that there is a protocol and guideline govern this one. It's not about your own preference. It's about, the patient's condition. Now, all our work is about patient condition. What about rivaroxaban? Do you have rivaroxaban in Qasim? Xarelto? I'm sure you do have it. Any patient now who get the DVT in King Faisal, they don't put him on warfarin, they put him on this one, rivaroxaban. It's a drug, direct oral anticoagulant, without, with no testing, no INR testing, no dietary restriction. And this is a drug, what are we going to do with the patient if he comes to the perioperative period? This is a problem. And we have to have a protocol for this one, and I will share it with you later on. Warfarin, for example. Patients on warfarin, a problem, bigger problem. What to do? To bridge, not to bridge, to continue, not to continue, to start low molecular weight heparin. When should we stop it before up? Of course, if we mess it up, if we don't stop warfarin on time, if we ask the patient to continue aspirin while this patient doesn't need aspirin, or Plavix, the patient will bleed, and the blood bank will suffer. If we don't, pay attention to those details, now we have many powerful drugs. People even take the rivaroxaban over the internet. They will say, I don't want warfarin, I will take this drug, okay? Or they will go to other hospital, they will come to us with that. And that's why this is what I said. A protocol is important, and to look at every single details is important. Otherwise, the patient will bleed, and you will require lots of blood transfusion. That's why what we do in King Faisal, the oral anticoagulant management protocol. Everybody should follow. It's not about your preference, it's about a protocol. Aspirin, warfarin, rivaroxaban, dabigatran, low molecular weight heparin, all of these one well organized, when to start, when to stop, when to restart after surgery. It's important. طيب. It's important here to know, okay, fine, we fixed all the medication of the patient. Now we will want to order blood. I'm a surgeon. I want to order blood for my spine. I need the blood definitely. How many units should I order? Should I order 10, 12 units? Cross-match? Blood bank will not give us. So I have to be rational, and I have to use some sort of science in my order. Like, what is this one? Something called maximum surgical blood ordering schedule. This is like a well-known term internationally. So it is standardized blood ordering schedule for patient undergoing elective surgical procedure. And how we get this number? Like how we determine that cabbage should have 4 units, spine should have 4 units, colorectal surgery should have 2 units. Based on what? Of course, based on the international criteria or ordering, and institutional. Like probably I have certain population. I have certain skills of surgery. I have certain skills of anesthesia. And I look at, for example, my last 100 colorectal surgery, what is the number of unit cross-matched over the number of unit transfused? And I develop this CT ratio. It's important. And I see the CT ratio. If it is really above 2 to 1, it means what? I don't use those cross-matched blood very much, and I have to reduce it. So I have to do some sort of calculation, and this calculation will determine whether I need, for certain procedure, no type and screen and no cross-match. For certain procedure will be type and screen. For certain procedure, I will cross-match 2 units. I may cross-match up to 6 units of certain, because I know those surgeries, they bleed. I'll give you an example. This is like in NHS. They have colorectal surgery. They look at their CT ratio. If it's above 2, it means what? They don't consume this blood very much. And they found that certain surgeries, they order 4 units, standard. Like in my hospital now, cabbage, 4 units. Pediatric VSD, 4 units. We said this is not good. So we calculate CT ratio, found that that's really high. It means we don't consume this blood gets wasted. So they did the same thing here. They found the CT ratio here 70.7 to 1, above 2. So what they did, revise the order, and instead of ordering 4, they ordered 2. And this is like, you have to do your own homework in your hospital for this one, for each procedure, and it's not difficult to do. I spoke to the blood bank earlier today about electronic cross-match. This is important. In my hospital now, we implement electronic cross-match. Any patient with no detected antibodies, and 2 separate confirmation of ABA blood group, will be eligible for electronic cross-match. And this means the blood will be issued within 5 minutes. And I know, Abdullah, you are getting this electronic cross-match soon in Qasim, and this is like good knowledge. Now we want the consumer, which is me, to be aware of what the supplier has. If I know that my hospital has electronic cross-match, I said, hello, blood bank, do you have a blood? No, we don't have a blood for this patient. We have to wait. Okay, is this patient eligible for electronic cross-match? Does he have antibody? Yes, he is eligible. So I know when I order blood, within 5 minutes I will get a blood. okay, in this unit. And that's why this is like actually what we have to do. The latest innovation that we're going to get in King Faisal is the electronic remote blood release. It's like, you know, vending machine, where you get like chocolate and Pepsi and this one, and you get like, you know, you are in the OR, you need the blood, you just go to the vending machine, this one, in the OR, you put the MRN number, it will know the patient ABO grouping, it will release the blood, which is really electronically matched with this one. And this is really the, you know, the latest innovation, and basically you will be comfortable that, oh, is there any blood for this patient? Can I do this patient? Can I do the surgery? I don't know whether I have a blood or not. Even the blood will be visible. There is a screen that this machine is not empty, it's available. And this will be the latest innovation in King Faisal and King Abdullah, inshallah, when it's open in June this year, inshallah. So now we know about the pre-op. We fixed the medication. We know how much blood we should order. We fixed anemia. And now the patient's coming to the OR. Is there anything we can do to reduce blood transfusion? What I'm going to focus about, intraoperative blood salvage. When I came to, after my training in 2007 to King Faisal, I was used to use cell saver in Canada for hip surgery, for orthopedic, for colorectal, for all these procedures to use a cell saver. Then I asked them, like, where is the cell saver in King Faisal? They said, well, we don't have it. You have it only in cardiac. Then I discovered this cell saver in the storage. And this was 2007. Brand new machine, covered with dust. We wipe the dust. We get it. Now, after like in 2007, now in 2017, we have a full service of cell saver. We have 4 people. Their job is to run cell saver. This is their job. This is the only job, is to run cell saver. And we have over 14 cell saver machine in King Faisal. Okay? So you see the difference and this one. So what is this cell saver? We are operating on a patient. The patient is bleeding. We have suction. The suction, of course, it will go to a reservoir. And if we reach certain, you know, blood unit, then it will go to the machine. It will process. It will have waste. And all what we'll get is RBCs. So platelets, fibrinogen, FFP, all this one, sorry, the plasma, all will be, you know, processed out. And all what we get is the red blood cells here. And this we get the red blood cells, this patient is on blood, we give it back to the patient. As simple as this. So reservoir, processing, washing, and all what we get now, we give the patients back as RBCs only. So to prevent the clotting, of course, you know, because the blood will go from the you know, the patient's side to the reservoir, we have to have some sort of anticoagulant. In the past, we used to give heparin. Now we don't give heparin, we put citrate most of the time in King Faisal, and this will reduce the exposure to heparin, which is very, very important. So when you look at the cell saver, of course, the cell saver it comes with different kinds, and this one, but even the ball sizes with the reservoir is different. So there is one for minimal bleeding, so very as low as 55 cc, 125, 175, 225, and it depends on surgery. If you have a high bleeding case, like redo cardiac surgery, if you have like, you know, let's say transplant or placenta accreta, you will put like the big ball size. If you just have like a small pediatric patient, you will have a small size. So it gives you actually the freedom of customize your service according to the patient. People say, there is any complication? What about contaminants? What about urine? What about cement in the orthopedic? What about, you know, all this surgical, it's all the things that the surgeons, they put. Of course, those contaminants are very important, and that's why it's always recommended to avoid sucking the contaminants, you know, the cement, the Tacocil, the surgical, all whatever. But there are published recommendation for every contaminant and what is recommended to be done. And you can have this manual, and you can just look at every contaminant and how to deal with it. But it means it's not a contraindication. So what we did in King Faisal, after we took this cell saver from the storage and we clean it and we use it, say the question now, we have now the infrastructure, we have the machine, we have the bowl, who's gonna run the cell saver? People get like, you know, in our culture, you know, if you give people extra tasks, they would say, no, it's not me. So we have like the anesthesia technologist and nurses. Usually these are worldwide. These are the ones who actually run the cell saver. So come on, anesthesia technologists, nurses will take representative from you and will educate you, will teach you in a course, in regular courses, how to run the cell saver. And we did over, until now, probably 25 courses in King Faisal. And we train many, many people, but we have champions. We have those 4 people that they're always there to troubleshoot, to educate, to be there if there is a question, if there is like, you know, some sort of concern about cell saver. What we do right now, we do cell saver in majority of cases. Hip surgery, for example. I'll give you, for example, hip surgery, before cell saver era, we used to, like for revision hip arthroplasty, routinely transfuse 2 units of blood. After we use the cell saver, 0 unit of blood. Erythroplasty, also drop. Liver transplant, we used to transfuse lots of blood. After cell saver, we dropped it to less than, like I would say, save 3 to 4 units per patient, which is really very important. Look at the caseload with the cell saver. As every year, we convince more services to get or to use the cell saver. Okay? Still, there is room for improvement. It's still like some surgeons, they are really reluctant. And this is normal. In fact, this is good. Because if you have people who are really resistant and they are against you, you will increase and improve your knowledge, improve your skills of convincing, and you will go to them and you will convince them again. So it will give you some sort of more skills and more knowledge. You see, like, for example, CCA Saver program, avoid blood transfusion percentage. You see, it was like about 30%, and now we're increasing, 60%, 80%, 20% total transfusion, up to 50%. So we avoided transfusion in many cases. We avoided actually this one. And it was like also a comfort for the operator, for the anesthesiologist to say, oh, we have a cell saver, it's okay, I don't need the blood to be in the room. Probably I don't need the blood to be cross-matched, okay? Especially, oh, this is electronic cross-matching, and I have cell saver, I'm happy, I can proceed, okay? So this is like the thing that, of course, you know your blood bank capabilities, and you know what's going on. Okay, can a service be created? Yes. Need demands for the service, needs sufficient devices, needs trained staff, needs clinical and anesthetic blood bank and technical and logistic support, need a visit, probably one of or 2 of you can visit King Faisal and see the workflow. This is important, see how it works, the setup. Why should you reinvent the wheel? You have a successful model, which is there about like 30 minutes flight from Qasim. So blood salvage. In cancer surgery, it is the question is, can we use it in cancer? Because the traditional, the old method that it is contraindicated. But you see there are like drawbacks. You know those cancer patients usually, they bleed a lot. They consume lots of blood products. They actually, their lifespan also is limited, is low. So is it ethical to take blood from a healthy trauma patients and give it to a cancer who's probably his lifespan about 2-3 years from now? So, and also blood transfusion by itself, it can actually promote metastasis, and this is well documented. So many cases published about using cell saver in urology, in cancer, in colorectal cancer, and with no complication and with no metastasis, and several reports. And the question is, of course, you know, when you look at, is there any solution? What we are worried about, if you have a patient with sarcoma, and we take blood, he has no metastasis. If we give him the blood back, will this cause metastasis in the patient? انتشر في جسمه كله? is there any solution for this one? What they suggest the solution is a blood irradiation. Fortunately, we don't have it in Qasim. Irradiation is just, I think you'll get it soon, and the oncology people, they requested that one. It takes 5 minutes. You expose this blood. Of course, you take the blood from cell saver already washed. You take it, detach it, take it to blood bank. 5 minutes, it will kill all the cancer cells, leave the non-nucleated RBCs, and it is like reported, published in many studies about intraoperative blood salvage cancer is safe and effective, okay, and by irradiation, which is really important. Obstetrics, which is really very important here. And what we worried about in obstetrics, we worried about amniotic fluid. If we take amniotic fluid and inject it and give it to the patient, will it cause anaphylaxis? This is important. That's why what we do in King Faisal, separate section. When you open the uterus, you suck the amniotic fluid, then when you are sure that most of it is sucked, you will use another section for the cell saver. And the other thing is, of course, we use proper washing and filter. And this filter will take most of the squamous cell that is related with amniotic fluid out of the blood, and you can safely transfuse. That's why it is actually well, documented that cell saver is essential in obstetrics. In our area, we are really very unique because we have number 3, number 4 C-section, placenta accreta, bibberida, and this happened in even small hospital. I went to a small hospital, Riyadh, private hospital, and I had a placenta accreta. It happens, okay? So the current opinion that cell saver should be standard of care in obstetric service. So what we'll do now, this is like, or I will finalize this one. What is our vision now in King Faisal? Our vision goes with now every institution in this country should have vision, 2030 vision. And our vision actually is to create this pre-operative center. And it's patient center. The patient will come, all the services will do their best to optimize this patient before the surgery, okay? Pre-op. Intra-op will use the best evidence, the best technology to serve our patients. Like, for example, we have all this technology now to test the Plavix, to test the aspirin, to see if the patient responder or poor responder to Plavix and aspirin. And we can use them within 5 minutes, and we know the result. And one day before surgery, we determine this patient cannot be done, and this patient will proceed. And we save a lot and avoid cancellation the morning of surgery. And this is very important, okay? And this is like the intuitive is the cell saver that we are expanding big time in King Faisal. And I believe that cell saver should be available in every hospital in Saudi Arabia because it will save the blood. And we know now the issue with the blood and blood bank, okay? They will do their best to supply us with the blood. We have to do our best to do blood conservation. And this is the future of anesthesia, and I think anesthesia will work more, and rather than to be only in the OR, to expand beyond the OR. Most of my work now, education, teaching, lectures, and this one is to other departments, okay? So I go to Department of Surgery, Department of Neurosurgery, Department of Urology, and expand the knowledge. So when I receive the patients, I receive the patients who is really well optimized, rather than I receive a patient who is on Plavix and aspirin, not well optimized, anemic, and then I struggle with him. So this is the future of anesthesia. Thank you very much for listening. Thank you.
Thank you, Dr. Amar, for this informative lecture. If there is any question?
Welcome, Dr. Amar. Regarding cardiac surgery, sometimes when we are going on bypass, there is a dilutional effect of prime solution. And this will lead to drop of hemoglobin from 11, 12 to 7, 6 sometimes. What is the solution if we want to come off bypass after that? How can to avoid giving the patient blood? Even sometimes if you try not to give, but the hemoglobin will stay below 10, below 9, below 8.
Yeah. So I think for cardiac, you know, cardiac is still in my center now. We consume in King Faisal about 30 to 35% of blood and blood products in the hospital. Okay, the benchmark العالمي يعني تقريبا 20%. So there's room for improvement. The problem in our center, we do many redo surgery. I think this is the careful. When you get to your patient who is anemic, you don't pay attention to, for example, to fluid before you go on bypass. You give them too much crystalloid, and you hemodilute them already. And they are like 12 and they become 10. And then you go on bypass, another hemodilution. And if the perfusionist is not meticulous enough to optimize the hemoglobin pre-op and during the cardiopulmonary bypass, I believe that it's about the skills, pre-op, intra-op, and to the perfusion. And by doing those skills, you can avoid blood transfusion in certain patients who are really straightforward cabbage, for example. Now, straightforward cabbage, most of the time they don't transfuse. And I accept hemoglobin up to 8.5, and I don't transfuse the patients. The problem you have to also coordinate with ICU, because you don't want to send a patient with 8.5 to ICU and they transfuse him blood. But this is the current recommendation. And of course, careful management of blood, pre-op, intra-op, and during bypass is the key for this one. And of course, the interaction with other centers and looking at the literature, looking at the way that they do is important to succeed. Now, as I said, below 8.5, I may transfuse the patient if he's continuing bleeding. Even if he's 9 and he continue and I see the bleeding. But if I see the patient is hemostasis is perfect and he's 8.5 or even 8, I don't. And he's hemodynamically stable. We are not treating number, we treat condition. This is important. Okay. Yes, go ahead.
Regarding departments using this device here, you didn't mention that general surgeons used it or they use it.
They do. They do. And I mean, I said most of the services in this one, they use it. They use it in different. Orthopedic, for example, becomes routine.
Regarding general surgery, regarding intra-abdominal hemorrhage or trauma patients.
Yes, you can. I mean, you can use it. There is no. In contrary, this is advantage. I mean, to have. Of course, if there is a clot, for example, you open and there is a clot, and this one, of course, you would not actually do the suction on the clot. Or I don't advise actually to dissolve the clot and do it, because already the process of, and the hemostasis or the coagulopathy started, and this blood will not be good. Sickle cell disease, for example, some relative contraindication, thalassemia, relative contraindication because it can induce sickling. So certain patients, yes, but other patients, the general surgery, this one, any patient who's bleeding, you can suck this blood, you can give it back to him. It may not actually reduce or abolish blood transfusion at all, but instead of giving him 6 units, you will give him probably 3 units, and this will be good for blood bank.
Thank you, Dr.
Yeah, تفضل.
It's very nice and
تفضل.
such facilities in our hospital, like
Yes.
cost and expertise and so. Can you
The cost. Yeah, I think as I said, it's the first thing is to get the cell saver. I know it's مناقصة الخليج. They're having a cell saver for the Ministry of Health. It will be logistically, it will be achievable and doable for you to get the cell saver. I think the other thing is when you look at the consumable. Of course, there is a consumable, and if you think about 1 unit of blood, the cost of unit of blood, if you go and continue the NAT technology and expensive testing and Sibahi, your 1 unit of blood will cost a lot, comparing to the one consumable, which will cost about 400 to 600 riyal. So I think, and also the other thing is the advantage of having the patient his own blood versus foreign blood and all the complication that we mentioned. And this is very, very important. For the staff, I think the company should train your staff, okay? And it's their obligation to train them and to create a champion, and this champion will teach the others. And you will find that if you focus on it in within 1 year, everybody will be able to use it in every room.
Sir, my question is how to prevent this bacterial contamination here in salivage?
No, bacterial contamination. If this patient, there is like an infected wound, for example, or this one, this is like a contraindication to go and suck this one. So you have to choose your patient exactly. But if, for example, there is a trauma case, tibial fracture or femoral fracture, and the patient is not, there is no infection, no sepsis, nothing, with a good tea, and the patient is bleeding, he can suck this blood and you wash it and you give it back. But if there is infected wound, no, this is not, don't do it. Okay, this is important, infected wound, yeah.
For the patient with hepatitis,
Yes.
we are using the same machine or different machine?
What do you mean?
AQU. For hepatitis, patient with hepatitis.
Yes.
After that patient, we can use for other patients?
No, because the consumable, it has to do with the consumable, okay? The consumable, when you look at the consumable, it will be removed and completely, discard after each use. You will not repeat the same, like the ball and this one. And when you look at the machine, it's all disposable.
AQU also is disposable.
Yeah, this is, of course,
In AQU, there is different machine.
I know,
Patient with hepatitis,
Sure.
non-hepatitis.
but this is different, I think. In this machine, most of the blood processing done by the tube, and this one, all this is a tube and ball, and this one. When you look, all what will happen is the hardware, but all the other, it's like, for example, the cardiopulmonary bypass. Everything we take, and we remove everything. We don't clean it at all. So it is different, I think, here. But this is completely disposable item that you're going to use.
So it's a closed system, so there is no contact with this blood. So there is no risk at all. It's the same.
Machine also the same. There
Yeah.
is disposable safe. After hemodialysis, we are...
So let's talk about your cardiopulmonary bypass machine. So it's the same machine. You will use it for
We don't use even hepatitis. We use the same cardiopulmonary bypass because this is like all. There will be no contact. The blood will not actually go from one patient to other patient because you completely removed all the disposable item. Any other question? So thank you very much for being here, and I'm happy actually to discuss. And if you have a question, please email me. Thank you very much. Thank you very much.
Congratulations.